clinical scenario of heart failure. Estimated prevalence of heart failure in India is approximately 1.3 to 4.6 million, and approximately 1.8 million hospitalization annually in India is because of heart failure. And it is one of the leading cause of hospital admission in the elderly population. And the age of heart failure admission in India is younger in comparison to the Europe population, approximately 17 years. And in hospital mortality in India is approximately 10 to 30%. In comparison to the Western counterpart, it is 4 to 7%. And all of you know heart failure is a chronic condition interspersed with the acute episodes which ultimately lead to the chronic decline. Each hospitalization deteriorates the graft very rapidly. And a lot of medical advancement have occurred from 1986 from HFREF trial to the Emperor reduced and HF trial. And heart failure is a clinical syndrome recognized by with current or prior symptom or sign caused by structural and functional cardiac with corroboration of any of the following like elevated natriuretic peptide level and objective evidence of cardiogenic pulmonary and systemic congestion. And based on EF, heart failure with reduced EF less than 40% is classified as a heart failure with reduced ejection fraction. And now the guidelines have recognized that another entity, heart failure with improved EF, where the baseline EF is less than 40% and there is a 10-point increase from baseline LVEF, and second measurement should be LVEF more than 40%. So this is a newer entity have come. And over the period it has been realized ejection fraction is not always static. Even in ejection fraction, poorer ejection fraction patients, approximately 1/3 patients ejection fraction improves, and even the patient HFREF, approximately 10 to 20% goes into the heart failure with mildly reduced one, and approximately 2 to 20% goes into the reduced ejection fraction. So some of the physicians, some of the time they are very much dogmatic about the ejection fraction values. It is a dynamic thing. It may improve treatment, without treatment. It can deteriorate even on treatment. So regular follow-up is important. And classical management of heart failure is a stage A. Stage A is a population which is at a risk of heart failure. There is no structural heart disease, but there is a conditions like hypertension, diabetes, coronary artery disease, or exposure to the cardiotoxic agents, or relatives of patients, those who have already genetic or inherited cardiomyopathies. So you have to take care of the diabetes, hypertension, coronary artery disease. Otherwise, they will develop the structural heart disease. And second stage is stage B, that is a pre-heart failure stage, means there is a structural cardiac dysfunction is there, but there is no symptoms. So if you are getting any patient with LV ejection fraction 40% or less, and patient is asymptomatic, in this subset of patient, ACE inhibitor and beta blockers are recommended. And if it is less than 30% EF is there, then ICD is recommended. If it is more than 40 day post MI, and you think the patient is going to survive more than 1 year, and if the patient with non-ischemic cardiomyopathy, apart from all treatment, genetic counseling and testing is recommended. The classical Gordon variety patient which we see in our day-to-day practice means stage C and D. Stage C is the practice patient which we usually see NYHA class 2 and 3 and 4. The step 1, establish the diagnosis of HFREF and initiate the guideline directed medical therapy. ACE inhibitor or ARB NYHA class 2 to 4, ERNI in NYHA class 2 to 3, beta blocker in class 1, MRA is class 1, SGLT2 inhibitor is a class 1, diuretic is a class 1 for the symptomatic improvement. If in spite of all these guideline medical therapy, titrate to the target, still ejection fraction is not improved, patient symptomatic status is not improved, then consider the patient for hydrogen dinitrates in the specific subset of patients. If you suspect NYHA class 1, ejection fraction 35%, it's not improving, ICD indicated. If there is a LVVV, NYHA class 2 to 4, ejection fraction 35%, QRS duration more than 150, not improving, then you go for the CRTD. But if still patient is not improving, that is a refractory heart failure, that is stage D, where you go for the LVSS devices and heart transplantation. So optimize right and optimize that early, strong HF trial have shown as early as you start all the treatment, you get the maximum benefit. So clinical benefit appears within days to week of GDMT initiation. So they have shown beta blockers, ERNI and MRAs and SGLT2 inhibitor. And you can see the maximum early benefit you get with the SGLT2 inhibitor, and as the time passes they become parallel. So you try to start as early as possible these 4 drugs. So take away from strong HF trial was more patient in high intensity group received the guideline directed medical therapy at 90 days. 55% have received the ERNI SRARB in 90 days. In intensive group, only 2% in normal routine. Beta blocker 49% versus 4%, MRS 84% versus 46% in usual strategies. So because in the intensive group there was a reduction in all-cause mortality in the intensive treatment arm. So our aim should be start as early as possible. So ERNI evidence-based beta blocker, when we talk of beta blocker, then it is a carvedilol, bisoprolol and metoprolol succinate, and MRA SGLT2 inhibitor. And all patients should have all these 4 class of drug until unless they are because of hemodynamics and electrolytes we cannot use it. And still if you patient don't improve, then if you are having still heart rate more than 70 on the maximum tolerated beta blocker, patient is still symptomatic, then you add ivabradine. If still patient is worsening, then vericiguat is a newer entity you should use. In African American population or chronic kidney disease population, hydrogen isosorbide dinitrate is a very good option. So vericiguat is a very new drug. Indication is HFREF LV ejection fraction less than 45% on maximum tolerated GDMT, and there is a worsening heart failure symptom. But here in vericiguat trial, SGLT2 inhibitor was not used. So if you see all these class of 4 of drug, so if you are the stage A, if you are dealing diabetes class patient, then SGLT2 inhibitor is a class 1 indication. In stage B, SGLT2 inhibitor in diabetes is a class 1. Otherwise, ACE inhibitor and beta blocker. In asymptomatic heart failure, ACE inhibitor and beta blocker is recommended. In symptomatic heart failure, ERNI takes the center stage, and then beta blocker, MRA and SGLT2 inhibitor diuretic for the symptomatic stage. And stage C and D. Here you can see SGLT2 inhibitor is all green across the spectrum, and all others are class 2B indication. And it has been seen if you are using a SGLT2 inhibitor along with ERNI, the chances of hyperkalemia is less. So these are these therapies enables tolerance of one another better. So the hyperkalemia induced by MRA is being taken care by ERNI. So overall chances of hyperkalemia becomes less. So that is the advantage of using SGLT2 inhibitor and ERNI together. Another important point, ERNI should not be administered concomitantly with ACE inhibitor within 36 hours of the last dose of ACE inhibitors. And in patient with HFREF during hospitalization, pre-existing GDMT should be continued and optimized to improve outcome unless contraindicated. Especially beta blocker, if a patient is taking before hospitalization, then until there is a compelling bradycardia, you should not stop. That is the newer recommendations. And if you are treating the patient and the patient is not improving, so the mnemonics is I need help, means I means intravenous inotropes, N means NYHA class 3B and 4, end organ dysfunction, ejection fraction less than 35%, repeated defibrillator shocks, more than one hospitalization, edema despite using the escalating diuretic agents, and low blood pressure, high heart rate, and patient unable to tolerate the medicines. So these are the patient need to be referred to the higher center where advanced heart failure facilities are available. Always there is a challenge which drug to start first, which not to start. That is important. You have to start all 4 drugs as early as possible. If you see number needed to treat, the best drug to reduce mortality over the long period of time is beta blocker. 8 number needed to treat 8 for beta blocker over the 5 year. It has been analyzed, and 14 for the MRAs and CRT, 15 for the MRS, 14 for the CRT and ICD, and it is for ACE inhibitor it was 21. and for its earning it was 11. And more than 4, another study where they have seen if you start all 4 drugs together as early as possible, then in 1 year where quadruple therapy was given, absolute risk difference was approximately 25%. So huge difference. And conventional sequencing was first start ACE inhibitor, then beta blocker, then MRA, then ERNI, then SGLT2 inhibitor. Now the guideline recommend there are few thoughts, beta blocker and SGLT2 inhibitor together, followed by ERNI and MRA, or you can first do MRA and then ERNI. And another is you can go anywhere depending upon the hemodynamics and another is start with the ERNI and SGLT2 inhibitor, then up titrate ERNI, and then continue with the beta blocker if patient is taking already, and then add to the SGLT2 inhibitor. And another is stable patient, shift ACE from ERNI and up titrate over 2 weeks and continue with the SGLT2 inhibitor at the first stage with beta blocker, and after 2 weeks you add the MRAs. But it is, I think it is a physician choice depending upon the hemodynamics and electrolyte reports. What guidelines say, very latest expert consensus comment, for individual not receiving any guideline medical therapy at the time of diagnosis, clinicians should aim to achieve optimal 4-drug guideline medical therapy no longer than 3 months following an initial diagnosis of heart failure. Means you have to have maximum dose, tolerable dose of all 4 GDMT within 3 months of the diagnosis. And another thing which was not clear for quite a long time, in this document they came very clearly, reassessment of ventricular function should occur 3 to 6 months after the target, matlab maximum tolerated doses of GDMT are achieved to determine the need for device therapy such as ICD and CRT. So now the 2024 position statement have made very clear. You try to get all 4 drugs both as early as possible, not more than 3 months. So GDMT, what are the challenges? Maybe symptomatic hypotension. It may be because of overdiuresis, maybe use of non-CV drugs, use of calcium channel blockers for rate control. That may create the hypotension. So you have to look for the other non-evidence-based therapies which may be the prohibitive in putting all 4 drugs. You remove that. In hypokalemia, consider increasing MRA dose if there is a hypokalemia, add potassium supplement, and worsening heart failure is another entity have come where the role of SGLT2 inhibitor have came, and another trial Solosis WHF have shown Solosis WHF sotagliflozin can reduce the heart failure hospitalization by 129%. Number needed to treat is 10. So based on this, in acute heart failure, SGLT2 inhibitor have been given the class 1 recommendation. So all 4 drugs as early as possible in most of the patients. And apart from that, comorbidities, iron deficiency, functional MR, care of AF, if there is a LVV QRS more than 130, CRT therapy. In black population, isosorbide dinitrate and hydrazine. In our setting, in pregnant ladies and CKD patient, you can use isosorbide dinitrate and hydrazine because it does not have any teratogenic effects. And if there is a recent worsening of heart failure already on GDMT, vericiguate is another choice. If it is still no improvement, label as an advanced heart failure. If patient can afford, you can go for the LVSA devices and heart transplantation. Sodium intake is also now the guidelines say don't go for very restrictive one. So up to 5 gram you have to allow. So the conclusion is HFREF management involves the 4 guideline directed medical pillar that include the SGLT2 inhibitor, ERNI beta blocker and MRA. Rapid sequencing is the new mantra, not more than 3 months, follow for 3 to 6 months. If still patient not improving, then go for the next step. When unable to up titrate, look for the diuretic overuse and co-prescribed drug like calcium channel blockers which don't have any survival benefit in heart failure. Try to achieve maximum recommended dose as per guidelines. Consider the role of iron, vericiguate and ivabradine whenever needed. And in stable patients, escalate the guideline directed medical therapy doses. Thank you for patience hearing.
If time allows for 1 minute, there is some. I want to add some very small points regarding the Dr. Soumik Ghosh. The question asked by Professor Sanjay Kumar sir to Dr. Soumik. See, taking a second opinion is always a good legal safeguard. So, in any condition when we are anticipating uncertain outcome like MS, even if it is mild MS, and we are in doubt that by the 9 month of gestation what is going to be outcome, then it is always good to take a second opinion. That is a legal safeguard. So you too can do it in case you are giving an opinion and you are not sure about the outcome. The second thing is about the gut microbiota, and I don't have any pro or against it, but I just want to mention two very small studies. There are several studies, but one study that concluded in 2019, that is a Chinese study, that shown that there was a systolic BP, reduction in systolic BP of 10.4 millimeter of mercury, and a Chinese study that concluded in 2020 with a reduction in systolic blood pressure of 7.3 millimeter of mercury. And when a meta-analysis was done of all the studies in 2022, that shown that there is a reduction of 5.4 in SBP and 2.8. Those are very small figures in diastolic BP. But it all depends on the candidate from where the FMT, the donor for FMT, fecal microbiota transplant. So it depends on the composition of the microbiota of the donor also. So it is still in infancy. No doubt it has a role in hypertension, but the role is not a replacement. It is less likely to be a replacement for the standard of care, although it may help as an aid, as one of the adjuncts to the therapy. Maybe in future with better FMP donors, with very selected microbiota, it can be a better option or a standard of care, part of standard of care. That is what it is now, right now. For refractory hypertension, people advise that FMP should also be done.
Thank you, Alok. Excellent presentation. I just want to ask you a couple of questions because I have always been curious. Whenever I look at those 4 pillars, MRA is mentioned always, but acute or even chronic heart failure with reduced ejection fraction, we always use the combination with loop diuretic. So why the loop diuretic terminology is not used?
Diuretics are
it just says diuretic. And the MRA is very specific.
Basically, when we talk of diuretic in heart failure, we talk of loop diuretic. For all practical purposes, our mean is that.
Okay.
I think for acute, again, initially
even for symptomatic, even if you see only loop diuretic and SGLT2 inhibitor is a class 1 indication across the spectrum of heart failure.
Yes.
Level of evidence is C. Because nobody can dare to treat heart failure without diuretic. If single drug have to give, so all of you will agree, if patient coming with the breathless, हमारे पास choice हो कि एक ही देना है तो हम लोग टॉक्सिमाइड ही देंगे. So because of that, randomization is not possible. That's why if there is a breathlessness and it goes with the logic also, if there is increased LVEDP is there, increased PCWP is there, so you have to give a PCWP.
So is it not like loop diuretics are used for acute stages for decongesting the patient, and MRAs have a long-term role in a long-term?
MRA have a proven survival benefit. Yeah. We have a randomized data for that. Loop diuretics is basically said for the symptomatic benefit, but we don't have conducted any study because it is not possible to conduct this study of heart failure without loop diuretics.
The basic objective of treating heart failure is first of all the symptomatic.
Yeah.
That's
so right. Whatever the drugs can give a symptomatic, immediate symptomatic benefit, that should be the first. After that, we have to prolong the life of the patient. We have to improve the systolic function of the heart. That is the purpose. Even if the patient is asymptomatic, there are some proven drugs which can improve. We can improve the ejection fraction, and they can improve the quality of life and the quality of the individual. So the prognostic indication is there. So in the prognostic indication, we are giving the very high diuretic And that propranolol is not having basically diuretic effect.
Yeah.
It has an anti-proliferative effect,
Yeah.
anti-coagulative effect, or anti-arrhythmic effect. So they are all the components which can lead to side effect of the heart failure. So that is the purpose. Diuretics is not the purpose of humanity. Our situation.
Yeah.
And Alok, in your clinical practice, where do you incorporate SGLT2 inhibitor? Very early in the first stage, or you start with the diuretic ACE inhibitor and then you go for beta?
I always SGLT2 inhibitor is मेरी बहुत मतलब first day one से start कर देते हैं.
So which one, EMPA or DAPA? What?
DAPA and EMPA, but basically DAPA is cheaper, that's why I use. Dapagliflozin and beta blocker is my favorite drugs, so I start with them.
And have you ever used that Riosigot in
I have
patients?
used, but
Wait.
Vesicate is very costly.
Yeah,
Victoria HF trial was basically, in that trial SGLT2 inhibitor were not used. But drug have some role, but the cost is prohibitive.
Yeah, that's what I wanted to ask. Yeah.
Benzoate, I think, is more safer drug.
Yeah.
Borderline TB. Because RDs and all these drugs which are being affecting a lot of patients.
And
in worsening heart failure is now being treated just because of the time that they can tolerate.
They have safety profile.
Again, what?
yeah,
But there is no mortality benefit with the Vesicate.
yeah, you try the GDMT. If it doesn't,
Yeah.
you have exhausted.
SGLT2 inhibitor have a cross the board.
But again, what Alok emphasized is patients come with decompensation. You have to decongest and start all the drugs in very small doses. That is what.
Now the guidelines are clear. Rather than up titrating, another advantage of SGLT2 inhibitor is that start initial dose and maximum dose is same. So from day one you get the maximum benefit. That is another advantage. And that's the same advantage with the MRA also. Most of the drugs we are prescribing plus combination, from day one we get the spinal electron 50 mg. So if you start with these two class of drugs, from day one your patient is on the maximum tolerated dose. That is the advantage.
Thank you, Alok.
Thank you, sir.